Hello, this is Sandra Kooij. I'm a professor on adult ADHD from the Netherlands, and I'm so happy to be able to speak to you about my favorite subject. It's ADHD in adults, especially ADHD in women, and their issues with hormonal mood changes and the female heart. Unfortunately, I wasn't able to come to Turkey and meet you all in person, but I hope this will be second best and good enough for you to get interested in this new topic. I'll share my slides. Here we go. Can everybody see it? I hope. So I have no conflicts of interest for this presentation except my own ADHD power bank here that I started with my colleague and friend Dora Weinschenk. We are both psychiatrists with many years of clinical experience and research experience in assessment and treatment of ADHD in adults. And instead of traveling the world and teaching everyone, we decided to make it available online for everybody who wants to learn. So just for your information. Yes, women with ADHD have as frequent ADHD as men, but are underdiagnosed, later diagnosed, misdiagnosed, or not diagnosed at all. And one thing that's important to remember when you meet a female with ADHD is that they may suffer from severe mood swings. That means in the week before menstruation and after giving childbirth and during perimenopause, they have really severe mood problems that are increased. And this is what women tell me. They are unable to focus in the week before menstruation. They are more impulsive than ever. They're irritable. They have anger outbursts. They're depressed. They're even suicidal in this 1 week. They're anxious, have panic attacks. Their sleep is disturbed more than ever, and the efficacy of medications for ADHD seems reduced. They call it danger week. Don't come close to me, otherwise I hit you. And the problem is it reoccurs every month, of course. We call this premenstrual depression, PMDD. We also know a syndrome variant that's called PMS, premenstrual syndrome. And in PMS, it's the lighter variant, basically, of PMDD. Only tender breasts, bloating, easy crying, and irritability happens in a lot of women to a lesser extent. But PMDD is a real disease, a real problem, because it's a real depression. And it comes back every month. It's associated with anger, irritability, low mood, suicidality, physical symptoms, pain, sleep disturbance, binge eating, substance use in that week. And you can make this diagnosis of premenstrual depression after 2 months of prospective monitoring of symptoms in the very premenstrual week by the woman. But women also reported their mood problems after giving childbirth and during perimenopause. And when I started looking into the data, there was virtually nothing. Only some data on premenstrual depression in the general population with a prevalence of 3 to 28%, depending on study methods. And nobody could tell me whether or not it was true that what the women complained about. So I asked them during this conference in 2016, and there were 200 women in this room, and I gave them this questionnaire about mood symptoms during the menstrual cycle, postnatally and perimenopausally. And nobody was allowed to leave the room without filling in the questionnaire. In this way, I was able to collect 200 questionnaires in 1 day. And we used these questionnaires together and we adjusted them for self-report. These are all well-known questionnaires and we have data on them from the general population. We also asked them, what should science study for you? What's your most urgent question to science? And the highest votes came for hormonal mood changes across the life cycle. So that's what I then started and what I'm reporting about now today. The first study in this conference I told you about found that the prevalence of premenstrual depression, postpartum depression, and climacteric mood symptoms was 2 to 3-fold increased in women with ADHD compared to the general population data. But because we couldn't be sure about the diagnosis of ADHD in all these women at this conference, we replicated it in our own clinic, where we asked 209 women with a diagnosis of ADHD, careful diagnosis, about with the same questionnaires. And we found similar results. Premenstrual depression was 45%, and this is maximum 28-29% in the general population. And they also reported an increased severity of symptoms. Postpartum depression, look here, 58%. It's really threefold increased compared to max 19% in the general population. And climacteric mood symptoms, the same, threefold increased levels of anxiety, depression, and somatic complaints. And this is a paper studied by Dorani in 2021, and here it is, so you can look it up at PubMed. But when you study the literature, you soon find out that ADHD women are not the only ones having increased severity of mood problems in the premenstrual period. It is also found in women with anxiety, obsessive-compulsive disorder, stress, PTSD, autism, binge eating, psychosis, mania, depression, suicide attempts, and alcohol abuse. So virtually everything. Every disorder is accompanied in women with a premenstrual exacerbation of symptoms and/or mood symptoms. And what we learned from the literature is that the effects of smoking and cocaine are reduced in the premenstrual week, reported by women who use these drugs. And of course, we need more research about what happens during the menstrual cycle with our medications, with the mood of our patients, and how can we handle this responsibly. And what we basically have no idea about so far is what happens in the brain when hormone changes and neurotransmitters interact. So there's very little research on hormonal influences on the brain in women in general. And this has a reason, because women were usually excluded from any research in the past because of the cycle, because the cycle induces hormonal changes, and hormones influence almost everything, every physiological system. So therefore, women were disregarded in research and only male participants were studied. And that's the reason that we are now here knowing nothing about the cycle in women and its impact on psychiatric disorders and physical issues. There were no studies in women with ADHD at all at the time I started this investigation. What I did find, however, was this, that dopamine, a neurotransmitter that's very important in ADHD and that we believe is dysregulated in ADHD, and the female hormone estrogen interact in the brain. They're closely related. They help each other's levels grow, and estrogen inhibits the degradation of dopamine. So if we have ADHD patients with a dysregulated or low dopamine level in certain brain areas, as we suppose is going on, and estrogen interacts and progesterone with these neurotransmitters, also with serotonin, there's a new area of interest for us. We should know more about it in order to understand our female patients better. Because, for instance, those sex hormones have been implicated in brain development to start with, and its maintenance. And those ovarian hormones, estrogen and progesterone, have similar effects as dopamine. They directly affect the brain regarding functions as cognition, memory, learning, emotion, and they influence reward-related motivation, impulsivity, and decision-making. So if you read these functions, it's as if you read ADHD dysfunction. So estrogen and dopamine have similar functions in the brain, and they work closely together. Estrogen upregulates dopaminergic receptors, and estrogen works especially prefrontally, where the main problems of ADHD are occurring. It impacts working memory by affecting dopamine levels. It affects the limbic regions, where it influences emotional and motivational behaviors. It influences blood flow and metabolic rate of glucose, And this changes during the cycle. This has all been investigated. So when we know this, we understand a bit better what might be going on in the brain in women with premenstrual complaints, don't we? Regarding progesterone, the effects of progesterone on the dopamine system depends primarily on the previous priming by estrogen. So it seems that progesterone has a lesser influence on dopamine changes and dopamine system. Estrogen does a lot more. Estrogen also protects the heart against necrosis of endothelial cells, the inner lining of blood vessels. It attenuates pathologic cardiac hypertrophy, so it keeps stuff together. And it may have a great benefit in aging as an anti-inflammatory agent. And estrogen is also known for its positive effects in autism and schizophrenia. It reduces inflammation, it activates T cells, it influences mood and cognition in a good way, it improves learning memory, and it reduces aggression, and it improves motor control. And we all know the sexual implications of the hormones as well. And there's many more functions to learn. Estrogen has many phases and influences not only the sex organs, fertility, but also the brain, the heart, and the immune system, the bone health, the bone density after perimenopause is reduced due to lack of estrogen, and neural functions. Also, glucose homeostasis is influenced by estrogen. So it's quite a vital hormone, I would say, and you rather not miss it or lose it. What I think might be going on is if we draw this line here of estrogen rising in the first half of the menstrual cycle, here it goes down during ovulation. Many women report symptoms here of mood and increased ADHD severity. Then estrogen rises again, and then it drops again under the cutoff of symptoms here, and then we have the last premenstrual week, 21st to 28th day, and then we have this premenstrual depression. If we consider that the dopamine level is low in ADHD, so as shown by this purple line, and dopamine is much higher in control women, then you can understand that although estrogen rises and falls and rises and falls, women without ADHD have not as many problems as women with ADHD because their dopamine is stable. So estrogen can go up and down, but our dopamine protects them from mood problems, cognitive problems, memory problems, sleep problems. But if you have a low dopamine level and your estrogen goes below the cutoff for symptoms, in your case, it's an individual sensitivity, of course, then you may develop premenstrual depression. Because dopamine and estrogen interact, have similar functions, and increase each other's activity. So another picture of the same is, this is the hypothesis. If you have in the first half of the cycle high estrogen but low dopamine in ADHD, control women have high estrogen and dopamine the whole follicular phase of the cycle, the first 2 weeks. But in the last 2 weeks of the cycle, estrogen is low in everyone and dopamine is low, and then the symptoms occur in ADHD women. But women without ADHD are still protected by high levels of dopamine and they have no symptoms. So this is just to give an impression, a visual impression of what I'm talking about. I think we can conclude that estrogen functions as a dopamine agonist and increases dopamine activity. So they both increase control over mood and cognition. But when both are low, as occurs in women with ADHD in the last weeks of the cycle, women have no resources left to keep up their attention, memory, and control over mood. And they may feel lost and helpless. And they also report a lower response to stimulant treatment in the premenstrual week, which may reflect the same. This picture is from Jeanette Wasserstein from the United States. And you don't need to read the whole picture, but this was a poster at the EPSART meeting 2 years ago. And it is what I want to show is this. This is the age at which ADHD is diagnosed in women the most. And this is the peak of diagnosis across age groups 40 to 55. And this is perimenopausal and menopausal age. So this effect illustrates what I'm telling you, that when estrogen drops and goes down and down and down and is low forever, women with ADHD will have more problems, more difficulties, because the little estrogen that was left is then leaving them forever. And then they cannot cope anymore, even if they have been able to function with more or less effort until that very age. And many women are now diagnosed around perimenopausal age, which is pretty late for a childhood onset disorder, isn't it? Okay, said enough. But what can we do about it? How can we treat hormone-related mood symptoms across the lifespan in women with ADHD? When we talk about premenstrual depression, we know that the pill can help if you take it continuously, so without a stop week. So 4 weeks of the pill and not 3 weeks and stop week. Because if you stop, you induce, again, an estrogen drop, which is hard to deal with in ADHD. We know that SSRIs are effective too. They have been studied for 20 years already. But what we recently tried, also to test our hypothesis about this interaction between estrogen and dopamine levels, we increased temporarily the stimulant dosage of women with ADHD who were already treated with stimulants. I'll tell you more about it. Postpartum depression, perimenopausal depression are treated with similar ingredients, hormones, SSRIs, and maybe also stimulants, to be continued. This is our first paper, Female-Specific Pharmacotherapy in ADHD, Premenstrual Adjustment of Psychostimulant Dosage. What we did was treating 9 women with ADHD and an established stimulant dosage that was effective. And they increased their dosage in the premenstrual week only 30 to 50%. And what we exactly did is described in every woman individually in this paper. You can look it up, it's open access. And all women improved with mood symptoms, and their ADHD severity was also stabilized. So they were enthusiastic, and this was easy for them. They didn't need to start an SSRI or the pill or whatever. They could just temporarily increase the dosage a bit. Their blood pressure and pulse remained stable, and there was no danger and no additional side effects. So that's interesting because it confirms the hypothesis that dopamine and estrogen can be compensating for each other. Then menopause again. Menopause women may enter menopause earlier than they realize and than we realize. It starts already at age 14 that estrogen levels drop. And in women with ADHD, it might even be earlier, before age 40. There's one study showing that, and many more are to come. The mean age of menopause, the last period is menopause, is 51. It says 55, but it's around 51 in Europe. And but before that date, you start with menstrual irregularity, shorter cycles, mood swings, loss of concentration, hot flashes, of course, vaginal dryness. Last period is here, and after the last period, you have loss of bone density, osteoporosis, and pain, and the initiation of heart disease. Thank you so very much. So it's really hard to lose your estrogen, and it's never to return, of course. Typical perimenopausal complaints, besides the hot flashes that everybody is aware of, is bad sleep, mood changes, depression, feeling tired, concentration, memory problems. So many of these symptoms look like ADHD a bit, and it's understandable that women with ADHD may think, I've always had difficulties with memory and concentration, but now I can't cope anymore at all. Now I'm completely stuck. I cannot function anymore. And that is also the time that women drop off their work in the midst of their careers. So that's a shame. But menopause comes with a lot of other surprises. Palpitation, migraines, headaches, muscle and joint pains, loss of bone density, fractures, urinary incontinence, vaginal dryness, sexual problems, dry skin, dry eyes, nose and mouth, loss of hair, sensitive breast, change of the female shape, increasing weight, restlessness, edginess, less caring, less able to multitask, swelling, edema, changes in voice, tinnitus, and weight gain. Well, this is not happening in men, I can tell you, and if it happens in men, it's only much later and slower. It's not so acute, leading to all these problems at once in menopause. Here, the bone density decreases with loss of estrogen, and here you see the difference. Men and women lose their testosterone and estrogen levels, but in women it goes like this here around perimenopausal age, and this leads to the fractures at a much younger age as compared to men. Yeah, so if hormones are so effective, and they are, for all the perimenopausal symptoms, they have been they have had a bad name recently, because since 2002-3, there were 2 major studies showing that female hormones after menopause, in older women, by the way, were associated with an increased incidence of cardiovascular disease and breast cancer. So many women stopped, and many hormones were no longer even available in Europe. And I think many women have suffered a lot in their relationships and their works and their work and their jobs, because there was no help for them available after that event. But those studies were, after second thought and after study, those data were presented way too alarmingly in the media and exaggerated. And the studies were in older women above 65, in which hormones are no longer so effective at all, and in which the incidence of breast cancer is increased anyway. So there has been a lot of discussion, but now the guidelines in Europe say that there are new hormones, and they are transdermal patches or gels or sprays, and that can be dosed very low and have no increased risk for any breast cancer. You should use those patches or sprays or gels together with oral progesterone, by preference utrogestan. Here's a dosage, and here's a dosage of the estrogen patch. And if you cannot use oral progesterone, you can also use the Mirena coil. This is the latest guideline from the International Menopause Society position statement. So this is good news for billions of women over the world who suffer from perimenopausal symptoms, mood disorders, bone fractures, and so on. And we should start early, not late. So as soon as perimenopausal symptoms emerge, you should consider using it, because if you wait too long, you won't get it anymore. Because when you age, your blood vessels become more stiff, and after the stiffness of the blood vessels may increase blood pressure too much, and then you cannot use it anymore. But if you start early, you may even continue longer than normally, because you keep everything more smooth with the hormones. Okay, then the other option I already mentioned, if increased stimulant dosage in the premenstrual week is effective in women with ADHD for their premenstrual depression and increased ADHD severity, what about stimulants during perimenopause? For instance, women who have had hormone-sensitive breast cancer, who cannot use hormones during perimenopause, could they profit from Elvans or dexamphetamine, lisdexamfetamine, I should say. And this has been studied in the United States by Neil Epperson here. And she has done 2 studies in women without ADHD. Look here. These were 32 healthy women in perimenopause with cognitive complaints. They received a placebo or lisdexamfetamine 40 to 60 milligrams a day. And there was a significant effect of stimulants versus placebo using questionnaires and a memory test. And blood pressure and pulse were okay. And this is this paper. And this paper is from last year for women who had who lost their ovaria due to cancer or chemotherapy, and they cannot use hormones, and they are getting into acute menopause, and this is very severe because all the symptoms I mentioned suddenly disturb your complete functioning. And then lisdexamfetamine was also shown to be effective. So this is very interesting. So basically, dopamine and estrogen are brothers and sisters, and estrogen may compensate for low dopamine, and dopamine may compensate for low estrogen. Isn't that new and interesting? So I think we should follow this research closely in order to help women better. Meanwhile, we're still not alone because there are other disorders in which hormonal changes and hormone therapy are also shown to be effective. This one is also very recently by a Dutch group showed that hormone therapy prevents relapse in women with schizophrenia or schizoaffective disorder. And also in perimenopause depression, estradiol modulates resting state connectivity in the brain. So very interesting to read that estradiol is in fact such an active neurocognitive and mood enhancer that we cannot miss it, or that we should consider to compensate for its loss if we cannot use supplementation. Then the female heart. The heart is also a problem in perimenopause, I told you already. And we should know and understand that heart infarction is the #1 cause of death in women in general. So for all women during perimenopause, you should consider heart problems and not thinking it's being stress only. And I'll tell you a bit more about the female heart. The female heart differs from the male heart in this way that women have a different presentation of heart infarcts. They have coronary artery spasms, whereas we are all familiar with ischemia due to atherosclerotic obstruction of arteries in the heart itself. And obstruction gives acute pain, nausea, and sweating, and everything we know about heart infarction. But the coronary artery spasms are much more gradual. They occur also during rest when you sleep at night in bed, but it's associated with stress, anxiety, and depression. So with psychiatry. And that's my colleague cardiologist, we suspect that women with ADHD who have lifetime stress, physically, mentally, always, never sleep, always busy, not able to relax, whatever, that their chronic stress may induce these coronary artery spasms in women with ADHD. I'll tell you why. These coronary artery spasms are difficult to diagnose because you cannot show it on an angiography, what you can do for atherosclerotic obstruction of arteries. You can see it on a scan, but not with spasms because they are temporary. Although you can now do it with an acetylcholine challenge test. I'll show you the picture. Here it is. This is the heart in rest, the heart vessels in the wall of the heart. And they're nicely the blood flow is nicely shown here. But this is the heart after acetylcholine provocation. And then the heart vessels, they have a spastic response. They close. And you see that there's almost no blood flow here in the heart, and this induces the stress heart, the pain of the temporary spasms in the female heart. This is what a spasm looks like. It's just a normal blood vessel. It's open, but it's temporary narrower. And here you see occlusion by cholesterol plaques. Atherosclerotic plaques inducing heart infarction. The risk factors for obstructive heart disease are that it runs in the family. Obesity, diabetes, high cholesterol, smoking, sedentary lifestyle, we all know about it. But in this spastic disease, you have a history of migraine, abortion, eclampsia during pregnancy, early menopause, thyroid problems, irritable bowel, hypertension, rheumatic disease, and Raynaud. And these disorders are all vascular in origin. That means if the vessels are inflamed or spastic in other organs, they may also respond this way in the heart. It's associated with stress, anxiety, and depression, as I told you. And whether or not it's also occurring in ADHD, we are not sure yet, but we need to investigate because we expect it to be, because all these problems occur a lot in ADHD. And the risk of cardiovascular disease, indeed, is predicted by endothelial dysfunction, by these disorders I already mentioned, in addition to polycystic ovarian syndrome, endometriosis, and premature ovarian insufficiency. These are gynecological hormonal issues that are also related to vascular dysfunction. The symptoms differ. Here in obstruction, you have chest pain after effort, and these symptoms are mentioned. But with spastic disease, you have a changing pattern of chest tightness. It occurs during stress, but also in rest or at night and during effort. So basically, in all situations, it may only feel as if your bra is too tight, as if you cannot sigh deep, as if you are in a harness. And women disregard the symptoms because they are temporary. It comes and goes, and they think, well, it's not coming back, so let's see. And this may be the first warning signs of cardiac infarction in women with these cardiovascular vulnerability. We know that male and female adults with ADHD have an increased chance of cardiovascular disease of 38% versus 23% in Swedish registry studies. And okay, we know that the mental stress that's highly occurring in ADHD increases the risk of cardiac ischemia due to spasms. And in women during perimenopause, there's an extra risk because estrogen drops that protects the heart and the blood vessels. Why did I start looking into cardiology? Well, my friend, the cardiologist, she said, I see women with ADHD. You describe women with ADHD, but I see them every day in my clinic. I was astonished. I said, is that true? How many? What percentage? And she couldn't say. And then we started screening because she said it's a lot, it's massive. And we screened with a short screener for ADHD, asking for lifetime ADHD symptoms. And she screened 300 perimenopausal women in her clinic, consecutive sample, and 35% of them had lifetime ADHD symptoms. So I was shocked. 1/3 of the cardiology clinic, perimenopausal women, had heart complaints and ADHD symptoms lifetime. And these women with ADHD symptoms were 2 years younger than the others. So that may be an indication of severity of the heart problem, that they started to be referred earlier to the cardiologist. And we wanted to know what's going on in this group. Do they have different heart problems? We couldn't prove that because we didn't have this provocation tests. That's quite invasive, and you need to refer to a hospital to do the test. So we have no objective data to prove that. But we published this first study screening in the cardiology clinic, and you can read it up in PubMed. The question is, indeed, are women with ADHD having more often heart disease? Yes, but are they also getting it earlier? And if that's true, what could be the explanation? And there are two possible hormonal explanations that are associated with ADHD. One is premature ovarian insufficiency, the premature menopause starting before age 40, so very early. And then you lose estrogen so young that your heart also starts suffering earlier. Same is true for polycystic ovarian syndrome, that's associated with infertility, obesity, and hormonal disbalance, may have a similar effect on the female heart. So we're now studying the prevalences of these disorders in this questionnaire, Women with ADHD Health Survey, and here's the QR code in the English version if you still want to ask your patients to join. So here's a summary why I think women with ADHD need our attention during perimenopause. Of course, all women have a decline of estrogen in this episode and increased risk of cardiovascular disease, but in ADHD those risks multiply because their ADHD persons already have an increased risk associated with ADHD. They have negative lifestyle factors such as smoking, substance abuse, chronic sleep loss, chronic stress, sedentary lifestyle, obesity, diabetes. They have these other disorders associated with coronary artery spasms. And we now know that stimulant medication also has a small increased effect on cardiovascular disease risk, especially hypertension and atherosclerosis. This is from last year. But this risk is much smaller than this risk. So everything together, we cannot not pay attention to prevention any longer. Sorry. We have to consider what estrogen does on the blood vessels and endothelial function. And the loss of estrogen is not an advantage for women with ADHD, suffering from mood, increased ADHD severity, and perimenopausal symptoms and cardiovascular disease potentially. We need to know the warning signs, we need to educate women, and we need to educate ourselves. That's why we started the Head Heart Hormones Network. This is the cardiologist I was talking about, Janneke Witkoek. This is the gynecologist that has joined us, Dorenda van Dijken, and this is me. And we are studying the relationship between ADHD, mood hormones, and the heart. What we want is to improve female health care, starting with ADHD and their health, women with ADHD and their health, but we will also extend our activities to women with other psychiatric conditions, because we have seen we're not alone. We have this website, h3network.nl, which has been partly translated in English so far, and we aim to do more next year. So here are the preventive measures that you could take in women starting from 40, because from 40 these perimenopausal symptoms emerge and estrogen levels decline. Your risk factors are family history of cardiovascular disease, a high BMI, blood pressure levels should be kept in order, cholesterol should be measured, blood sugar should be measured. So not assume it's okay, but start measuring it from age 40. You must move a lot, at least 30 minutes a day, and also do some cardio fitness if possible. And smoking should be stopped, because we all know women and men with ADHD smoke twice as often as others as compared to controls. But smoking is also related to early menopause and reduced estrogen levels. So that's a good reason to stop. When you find a woman with an early onset of menopause, before age 40, she deserves a hormone suppletion therapy to protect her heart, bones, mood, and cognition. Otherwise, she will suffer and will not be able to function. What should we do? There's always a lot to treat in ADHD. There's a lot of comorbidities, for instance, sleep, anxiety, depression, those hormonal complaints, and the physical diseases. We should start with prevention of cardiovascular disease from age 40. I mentioned it. And then we treat ADHD, followed by lifestyle adjustments. This comes only as a last intervention, because if you start with it, people can't cope. They cannot do it because they're still exhausted, anxious, depressed, or having severe ADHD. You can only do it once you have treated all conditions. And then we start lifestyle adjustments. Yes, we think treating ADHD might benefit the heart. Why is that? Because the stress of ADHD, the stress of sleep loss, of anxiousness, of depression, and the menopausal complaints is a huge stress to the body, to the blood vessels, to the heart. It should all be treated. We should take psychiatry seriously in order to protect the body, the heart. And of course, psychological treatments such as reducing work overload, high pressure at home, perfectionism, low self-esteem, and so on should also be addressed, maybe by schema-focused therapy and a gut-friendly diet, walking outside, learning to ask for help, sports, physio, massage, meditation, and breathing exercise. There's a lot you can do. Thank you so much for your attention. Here are some resources for your interest. My book, Adult ADHD, several podcasts and webinars on YouTube, and our own ADHD Power Bank with 38 videos now on ADHD assessment and treatment, including comorbidities. Thank you so much. I hope you have a wonderful meeting, and I hope to see you soon in another conference. Bye.